बिस्मिल्लाहिर्रहमानिर्रहीम। रब्बी इश्रह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली। अल्लाहुम्मा इन्नी अस्अलुका इल्मन नाफ़िअन रिज़्क़न तय्यिबन व अमलन मुतक़ब्बला शिफ़ा मिन कुल्लि दा। Today the topic of discussion is management of labor and delivery. This is Dr. Zunaira, Faiz, gynecologist. I want to tell you about the labor and the delivery. It's little bit important points. Subjects to be conveyed, that is induction of labor, delay in the first stage of the labor, and when and how to intervene in the second stage. Who needs a caesarean section? Risks associated with caesarean delivery. Why are there so many caesarean sections? Resources: Cochrane database, RCOG guidelines, NICE guidelines, and Lawson, Harrison, Bergstrom, maternity care in developing countries. My personal experience. Why is this subject important? Difficulties in labor is responsible for 30 to 50% of the maternal death, morbidity in survivors, fistulas, anemia, infertility, and also has increased fetal and neonatal risk. Caesarean section in Western countries is the simple and safe option, but late presentation, resources, and make it less appropriate elsewhere. Predicting outcome in labor is still difficult. Clinical examination is limited. X-ray and CT pelvimetry is disappointing. Estimates of fetal weight has a wide margin of the error, and antenatal risk screening is still important, but mostly to decide place of birth rather than mode of delivery. Antenatal risk factors: young and older nulliparous, short stature, previous difficult birth or caesarean, previous stillbirths or neonatal deaths, multiple pregnancy, nutritional deficiency, severe anemia, large fortaves, obvious pelvic deformity and malpresentation, high parity. When to induce labor? When the risk of continuing the pregnancy outweighs the risk of induction. At 41 weeks plus, within 96 hours of the ruptured membranes at term, for preeclampsia at birth, for maternal diabetes at term. This includes gestational diabetes. When to induce labor too? For IUGR, intrauterine growth retardation at term, when there is absent Doppler and diastolic flow. Macrosomia, no significant data. Multiple pregnancy, no data. Previous precipitate delivery, no data. So unstable lie, still no data. Cholestasis of pregnancy. How to induce labor? For prolonged pregnancy, first sweep the membranes. For ruptured membrane, oxytocin by IV infusion. Although wait and see and vaginal prostaglandins, they are acceptable. For all other patients except those with a uterine scar, vaginal prostaglandins, regardless of the state of cervix or the parity of the patient. Amniotomy followed by oxytocin infusion 3 to 12 hours later is likely to be the most cost effective when the cervix is ripe. After one previous lower segment caesarean, for spontaneous labor, the risk of scar rupture is 1 in 200. With oxytocin infusion, the risk is 1 in 100. For prostaglandins, the risk is 1 into 40. More difficult to induce. Direct effects of prostaglandins on connective tissue. Based on this data, and Foley's catheter is an acceptable alternative. For oxytocin infusion, use a single standard dilution in normal saline, intravenous by infusion pump. All instructions in milliunits per minute. Commence at 1 to 2 milliunits per minute. Increase at 30 minutes interval. Review at 16 to 20 milliunits per minute. Discontinue after 5 units if not in labor. Monitor the fetus. Oral misoprostol. 41 trials and the method of induction of labor. It shortens the labor and less likely to need the caesarean section. More likely to have hyperstimulation. Oral misoprostol more meconium and when compared to the vaginal prostaglandins, less likely to have hyperstimulation, more likely to require oxytocin, and colloquially it is unlicensed in most countries. Dosage is still uncertain, should not exceed 50 microgram. Delay in the first stage of labor. Back to the basics, that is best diagnosed by reference to a partogram. Defined as dilatation less than 1 cm per hour in the active phase, this represents the lowest 10th centile, is regardless of parity, but the biggest difficulty is deciding when to start the partogram. Evaluation in all about, that is power, uterine contractions, oxytocin augmentations, safe enough in the most nulliparous. So in P's, that is a power, passenger and passage. The first is the powers, that is uterine contraction, oxytocin augmentation, and then is the passenger, presentation and position. Estimating the fetal weight, beware the multipara. Passages. Is the labor obstructed? Then is the psychology, pain, relief, and rehydration, etc. So in my practice, I will make a personal evaluation of the patient. Begin with the antenatal record, talk to the patient and the midwife, evaluate the uterine activity, examine abdomen and vaginal examination, arrange analgesia if required, commence oxytocin 1 or 8 millunits per minute, arrange continuous CTG, cardiotocograph, review in 4, 6 or 8 hours. When to intervene in the second stage of labor, a few patients should not push at all. Otherwise, there is no reason to interfere unless there is failure to progress. This usually means a rest after 60 minutes of active pushing. Not just full dilatation plus 1 to 2 hours. When the patient and others, they are ready for intervention. Fetal welfare in the second stage must take into account the total clinical scenario. For me, this begins with the antenatal record, then the partogram prior to the cardiotocograph, that is CTG. The depth and width of fetal heart rate dips is more important than their types. Explain to the mother why you are intervening. Forceps or vacuum. Less maternal trauma by Ventouse, less anesthesia is required, and more vaginal delivery. More neonatal cephalohematoma and retinal hemorrhage with Ventouse delivery. But serious injury is rare. Ventouse equipment is a problem. You can see in this, the Ventouse, there is a cups and then cup and then chain, and then behind is the vacuum creator. Vacuum is created and which is transferred to this metallic cup, which is already applied to the fetal vertex, and then we push it when the certain pressure is developed, and then it leads to the delivery. The Kiwi Omnicup Ventouse. Conventional Ventouse, they are more successful. Omnicups, they have more detachments. No differences in maternal trauma. No serious neonatal injuries. Trial of Ventouse in theatre. It should be when the fetal compromise is suspected. And an even better option is scalp sampling. When there is marked caput and molding, when you are not absolutely certain of the position and there is a role for intrapartum ultrasound, and when there is 2/5 head or more palpable above the brim. Advances in the Caesarean section, spinal anesthesia as it is safe considered, and there is a Fenton strip type of incision, cord traction for the placenta, peritoneum which is not sutured, suture fat if more than 2 cm but do not drain, prophylactic antibiotics, and early oral fluids and ambulation, rectal non-steroidal anti-inflammatory drugs for analgesia, and confirmed by randomized controlled trial. So who needs a cesarean section? I really don't know, but many of my obstetric colleagues seems to know. 50 to 70% of the cesarean, they are now elective procedures, and we should be aiming for 100% elective cesarean section, because non-elective cesarean section is the worst of the 3 options. Now, I will end the part 1 of this lecture here, and I will continue with the part 2 of the lecture, inshallah, with the absolute indication of the cesarean section in my next episode, next part of this lecture, part 2. Thank you very much. Jazakallah khair.